Right, good afternoon, everybody. Welcome to this SDEC and Single Front Door session on behalf of APEM and a desire in the community of all of those who do either peds emergency care or acute pediatric care or anything related to acute and emergency child health. There's been a lot of discussions, especially on the Heads of Service WhatsApp group for children's emergency care about these concepts of SDEC and single front door. And I just wanted to start having maybe a sharing of information about it, because there are some people involved in some things, some people who aren't, and it would be good just to share goodwill. I'm Damien. I'm a paediatric emergency medicine consultant and head of service at the Leicester Royal Infirmary. I've been involved through some connections with NHS England with a working group on paediatric SDEC, as have some people on this call and some others. And I'm also currently the NHS England lead for the deteriorating child. And a lot of that to do is my work with Pews. But because of the way that the health system is changed massively since COVID and now, how we move children around the system, or how children move themselves around the system, is becoming increasingly important. So the plan of this session is I'm just going to present, hopefully for no more than 5 minutes. And then we've got Jane, I'm hoping from Southampton, is going to present some of her experiences. And then we're going to open up for some of your experiences. But hopefully most of this is going to be in hopefully a Q&A format. But without further ado, I will kick off with a little presentation, which I hope brings home so that we're all on the same page, essentially. So we have children and young people at home, and in wherever they are, that is kind of with their parents, carers, etc., child becomes unwell. And at that point, they either choose to self-care, they may phone 111, or they may choose to seek out a healthcare professional. And that might lead them ordinarily to a primary care provider, such as their GP or an urgent treatment centre, or that they can choose to go to any number of emergency departments. And for those children that seek out a GP or a UTC, those children can be pushed forward onto an emergency department should the healthcare professional think that was necessary. And that either from primary care directly or through an emergency department, you can end up in a hospital. And that's been a model that has been around for quite a while. But actually, pediatrics has probably been ahead of the game, because probably a good 20 years or even more so, actually what was the more likely destination for you, either coming through a GP or an emergency department, was to go to an assessment unit. And that assessment unit may be part of a ward, or it may be a standalone assessment unit within a hospital. And what that meant is that there was a barrier is the wrong word, but a gateway into hospital wards, because it was felt so many children could be turned around quite promptly, needed perhaps less than 24 hours of care, and didn't need a full admission to hospital. And the majority of pediatric admissions were less than 24 hours. So that we're really used to this assessment unit model. And you could argue that we've had pediatric same-day emergency care for some time now. And that is that you could bypass the need to be in an emergency department, or that you can bypass the need to be on a hospital ward by having this assessment unit context for those children to be seen by a child health specialist and then sent home. So what is same-day emergency care? Well, this is a definition taken from NHS England, and it essentially says that it allows specialists to care for patients on the same day as arrival to avoid hospital admission, and it removes delay awaiting for kind of further investigation and treatment. Now, this is a definition that has been, I suppose, agreed and confirmed. You may not agree with it, you may not like it, but it needed to start somewhere, and this is how things have played out for the moment. And that the NHS long-term plan mandates that if you're a hospital with an ED, excuse me, sorry, that you must have medical and surgical services at least 12 hours a day, 7 days a week, to operate this SDEC model. Now, in Leicester, quite a while ago, we noticed that we'd had an assessment unit model, but we also had a number of paediatricians working in our emergency department. And we found that there was quite a bit of duplication, i.e. that a child would come into the ED, would be seen by a paediatric emergency specialist, and then would go up to the assessment unit to be clerked again by an SHO, maybe go back up to a registrar and a consultant, only to be sent home. And we felt that was a bit of duplication. And then we also found that the assessment unit itself was becoming increasingly overwhelmed and didn't have the functionality that emergency departments have in terms of space and escalations. And so that patients got gridlocked in the ED, either when they needed to be on an assessment unit, or that primary care started referring straight to the emergency department because the assessment unit was closed and the emergency department was the only place that was open. And so we thought about this model of having a single front door so that we would move the assessment unit into the emergency department. Now that requires just a bit of thought, which I will only spend a couple of minutes on. But what we felt is that if you have a single front door so that all patients who either walk in or are referred by a GP or 111 or another kind of provider, whether that be specialist nurse, etc., come to the single front door, a lot of them are assessed and treated within the 4-hour window. Some of them are seriously unwell and need transfer out to ICU. There's a larger number who have what we call stable physiology. They don't need loads of intervention, and they're likely to be in less than 18 hours, but more than 4 hours. So they'd go to what would be a short stay unit. Some of those patients would need some hourly interventions to begin with, maybe hourly nebulizers, for example, or regular GCS, but would still likely be in hospital less than 18 hours, so would go to the children's Shortstay unit. And then you would have some patients who would be stable, but you're likely to be in more than 18 hours. So you've got a neonate who's febrile, likely to be septic, you've got kind of a positive dipstick. So they get bundled up, get their antibiotics and go on to a medical or maybe a surgical ward if they've got kind of appendicitis. And that's how we felt that things would work. What we realized, though, was that there was a group of patients, and this is a second yellow group, who need regular interventions, but the ward didn't have the capacity to facilitate that. And so what was needed was an acute care bay or a 46-bedded admissions area, not an assessment unit, not a decisions unit. These were definitely coming in, but their intensity meant they needed an admissions unit before going to a medical ward. And this was a model we would have liked to have run in Leicester. What actually ended up happening is that we didn't get the admissions area, and our short stay unit has been difficult to staff, especially so recently. But essentially, we run this model whereby all patients within the Leicester area, whether they're a GP referral or a walk-in, come to the single front door where the pediatric acute team are there as well as the ED. Now, I'm going to stop sharing now, and I'm going to pause for thought because that's literally a rapid run through of a bit about kind of same-day emergency care and a bit about single front door models. I'd be interested in questions or queries at that point. The easiest thing to do is either raise your hand. I've got a couple of those, or stick something in the chat. So Dave, Hannah, I will come to you first.
Thanks, Damien. Quick question. In Cardiff, we have geographically distinct paediatric emergency unit and children's assessment unit. PDD is where we're based. Children's assessment units where the general paediatric team are based, and they take the GP referrals. In your system in Leicester, where you have it sounds like sort of the paediatric team in ED alongside the ED team, is there a segregation of patient populations, or do they all come in, get booked in, and get triaged the same way?
Good question. So all patients have walk in through the front door. They get what's called a Vac Assessment. So we have a nursing member who looks at you and decides, actually, are you extremely unwell or not? You then, all patients, regardless of things, get a common assessment as per the intercollegiate standards, ideally within 15 minutes, but that is a real challenge. And then they go into a general illness queue, essentially, or an injuries queue. And in that illness queue, the paediatric team will be looking out for patients that they're expecting because they've been formally referred to that team. But there's also a huge number of patients we found now who the GPs or other system members are just sending to us, who are technically a referral, but haven't been actually formally spoken to the paediatric team. And that those people get picked up by both of us. I'm labouring that point because Bob Passu has put in the chat, any resistance from general peds ward team. And yes, that there was concern, anxiety, unease. It hasn't been an easy process over the last couple of years, but things are infinitely better than they were. And determining, and I hope that some of the London teams have really managed to nail this down, are on the call about actually having a single queue. We have a single front door and we're nearly at a single queue, but not quite. In a way, what we'd like is to pool all our resources and everyone sees everyone, but we're not quite there yet. Does that make sense, Dave?
Yeah, very helpful, Damien. Cheers.
Cool. Now, sorry, I've lost my little thing about who, someone else had their hands up. Oh, that seems to have gone down. Okay, so answer Bob. So how do people define what is SDEC, what is PSHOT, what is rapid access? Okay, I'm not going to answer that question now, but I would like us to get onto that because that's really important. Have our attendance numbers gone up dramatically as the general public hear about this? Yes, they have gone up dramatically. The question is that a result of the general increase in presentations? Do the public learn that if they just come to us directly, they may well be seen by a paediatrician? I'm sure that happens, but I don't think that's as widespread as you may believe. But we can clearly demonstrate that we've moved our assessment unit that never came through the ED numbers into our emergency department numbers, and that clearly massively increases our numbers. And the staffing model can be a challenge. What we kind of did was basically take our ED contingent and mix it with the Children's Hospital contingent. We do have some challenges at night because we probably don't have the right amount of senior staff at night, given the volume of patients who are coming through the single front door. Okay. Ian Lewins, can I put you on the spot? Do you want to briefly speak about Derby, since you put it in the chat?
Oh, really?
Sorry.
Hello. I'm Ian Lewins. I'm ACD from Derby. And as I keep reminding Damien, he used to be my PRHO a billion years ago. So Derby is DGH with, I was going to say 36,000, but we'll have to correct up to 40,000 attendances a year. And we have, since we built on the site, a single front door policy since we opened. So we see all the walk-ins, all the GP referrals, midwife referrals, health visitor referrals, 111 referrals. They are seen by the PDD team. And we also have an on-site co-located GP service. So those children who come in who are triaged as category 5, essentially needing primary care and not emergent care, can be streamed to our co-located GP, which is supposed to be open 24 hours a day, but invariably stop streaming when they get too busy. And we also, a few years ago, built a paediatric observation unit on site, which is next door to our ED, which is again run by us, which is open from 8 a.m. to 2 a.m. dependent on staffing. So for those kids who need more than 4 hours care, but less than, as Damon sort of says, something 18 hours care, we could look after them. So we took ownership for those, and it avoided the 0 days admissions. And again, as I'm sure everywhere else has struggled with staffing, we've not been able to open it for weeks, if not months recently. And we have a very good sort of reputation locally, which means that everybody piles to us, which has its pros and its cons. And in terms of staffing, we are sort of a mixture of PEM consultants, paediatric consultants, adult and peds consultants, with no middle grade, and then sort of SHO grade and ACPs and ENPs.
Brilliant. Thank you very much, Ian. And please do stick in the chat if you've got a model that you'd like to discuss. We've got plenty of time to do that. But picking up some of the other questions, has this helped with our flows, and have we got numbers? And I think has it reduced admission? So definitely the national average of, if you look at admissions from ED, is actually higher than you expect. It can be up to 20 to kind of 25%. At times when we are working at our most efficiently, our admission rate can be down to 6% toward admissions because of this model. Now, some people might say that that's actually a bit too low, but it definitely completely cuts out a whole load of very unnecessary ward-based admissions, even when our CSSU is closed. Now, that does mean that you have long waits in our department, and you could argue maybe that's a bit of a fudge, but it definitely does hugely reduce ward-based admissions, and most patients who end up in hospital really do deserve to be there. And we can demonstrate that because the length of stay in the children's hospital is actually quite long, sometimes 2.5 days, which is well above kind of national averages, and that's because of this sieving of acuity. So the patients, Liz has asked about kind of who gets the paediatric review. The real aim is that what we've got is all of those with paediatric background can provide that paediatric skill set to everyone on the floor. So you're maximizing the impact of those with paediatric training. Does the EMT end up seeing only injuries in the paediatric team, only the illness? No, I think a lot of the EMTs still see illnesses because we've got so much of it, but the paediatric team don't see injuries. And we've got a bit of work, I think, to do locally on maximizing the work of our injuries team. If we used to have a co-located GP. We've now had a GP working, or GP stream working within the ED. It's now just outside of our ED in a mobile bus, essentially. That's where our kind of a new urgent care centre is, and we're working really rapidly as a system to work out where UCC sits. But we've been to and froing about having GPs within and outside of the department. In terms of the funding, this is a really interesting one. You could argue we've been helped by the COVID change in just having block funding. If we'd have carried on tariff, I think the Children's Hospital would have demonstrated a massive loss, and that is something that happens. But I think depending on who your ED is owned by, you can come to some kind of business agreement regarding that. Okay, so and then a load of sorry, just running through the admission rates. Yes, okay. Julianne, I don't know, did you want to just talk about, because you've always had a single front door, and your experiences of that? or maybe mic is not working. Okay. John Adamson, I don't know if you got a mic. I'd be interested in, Birmingham's gone through quite a load of changes in the last couple of years ago. Do you want to fire away on what you've been doing?
Yeah, well, through the pandemic, feels like we've tried just about everything, to be perfectly honest. But we went actually, in part of the pandemic, we went to near enough a full single front door model, and have since gone back. Our general paediatricians weren't very keen on it, is one aspect. The part of the reason we did it in the first place was to do with the segregation of the geography as far as keeping likely COVID patients or at risk of COVID patients away from those who weren't. Obviously, when the numbers dropped to 75 to 100 patients a day, that was easy enough to do. But now that we're getting 250 a day, it's not really possible. So we've kind of gone full circle back to the model that was in place really when I started 3 years ago, which is there's a single door, but you go into now one of multiple queues. So we have anyone who's been referred by a GP with a medical problem basically goes through to the CDU area, which is close but separate, which is where the paediatric team are based. And then anyone without that or anyone with anything else stays in the ED. Although we have in the last few months worked on an agreement with Operos Health to have, which is running local walk-in centres, and we've basically co-located a primary care setup. I say co-located, it actually sits kind of effectively across the other side of the ambulance bay in our fracture clinic. And that runs from 5 till 10, although it's actually going to start running from 2 till 10. They generally offer 3 slots an hour, which we book into. We kind of used actually those who have been involved in whose departments have used 111 first, and that set up the kind of booking system that came into place in order to facilitate the 111 first thing, which has never really quite worked in the way it was supposed to, has actually enabled us nevertheless, whilst walk-in centres and 111 could book into us. Now the reverse is effectively true. So they offer us slots, and our reception, if they've been triaged suitably and the nurse in charge or consultant in charge is happy for them to go to that route, then they actually effectively, unlike Aleister where they would stay within the footprint of and kind of on the list of the ED, they get discharged from our system and booked an appointment effectively, even though it's just for the administrative purposes really, but they basically go and wait in a holding area, which is the physical space is what during the daytime would be fracture clinic. So that's kind of that. What I would say about that is that has been a massive boost in terms of overall performance, because the numbers we're getting are just becoming staggering. And although our, if you like, the sort of percentage performance against the 4-hour clock doesn't look any better than it did a year or two ago. You know, we're seeing maybe 20. I saw your tweet the other day, Damien, about 50% increase in attendance. We're probably more like 25. And that's without really changing the model. I appreciate some of your rise has come because of effectively taking the CAU patients when that merge happened. But this is, you know, kind of effectively the last month in March was a true 25% increase on the previous year. So our ability to deal with those sorts of numbers has improved as a result of the primary care stream. And I think, you know, we're probably all experiencing that, whether it's true, perceived or otherwise, there is definitely a large amount of primary care work coming our way. So that has definitely been a big help.
Fantastic. Thanks, John. Okay. I mean, if there's anyone, I'm keen to hear from a whole variety of units. If you want to stick in the chat or elsewhere, if you want to just discuss what you've been doing. But just picking up on a few comments, Jane Bailey for Southampton is talking about what to do with some of these children who need NG tube replacement, or kind of PEG or PD catheter issues, we have all of those come to the ED as well. And actually mixing with the general populace probably isn't ideal, but there is nowhere obvious for them to go. And I suppose picking up, I think Rachel Mitchell from London has been any safety issues for those that don't have a single front door. Well, I think that you do get a huge variety of patients coming to the ED. And previously, although we've not had major problems with it yet, one of the things in COVID was extremely clinical vulnerable children would always have to come to us first potentially and not be able to go straight into a cubicle on a ward. We're blessed actually with a lot of cubicle space within our ED, so I don't think it's a massive issue because we'd always be able to move someone out. But I would get, if you're a smaller unit without lots of cubicles, that is something that that you'd need to think about. I think people had also asked about kind of how does the out of hours staffing work, and yeah, overnight it can be challenging, but traditionally you should get much less referrals, especially from primary care out of hours anyway. What we're finding though is that we have just got such huge numbers coming, especially early evening, that we've got this mass of patients still in the department at 11 midnight. And it's really tough on our night teams at the moment to work through basically what is virtually every referral in Leicester, either walk-in or from a GP or a UCC. Okay. I'm just picking up Aleister Morris in Halifax. You're in the process of moving. I don't know, is there any specific questions that you wanted to ask, or where are you in that journey, and what are you doing at the moment?
So we're probably 2 or 3 years out of a new build. We're in process of putting something in place in the meantime that isn't single entry, but is paediatrics working down in ED to get those sort of co-working together. I think my main thing is around sort of, I'm really keen to see your numbers on admissions and flow and things offline later. Sort of observation unit opening times, best length of time for those. I mean, we were looking at 6 a.m. to maybe 2 a.m. most max, would just to drive making decisions and not keeping people in. Anybody found anything around best opening times? Dependent on staffing, of course.
Yeah, that's if people put stuff in the chat. I mean, we were, I suppose, modeled to have a short stay unit that was open 24 hours a day, and we've struggled with staffing that, if I'm honest. I don't know if people wanted to put those you do have observations units, what times you have it open to. It is a big difference between staffing something 24 hours and having something that maybe is just during the day into the evening. Yeah, and then just a question on staffing, and just to pick up a load of questions on how it affects your attendances. It is really difficult to work out, and I know I've had a load of questions from Plymouth on this, is when you go to this change model, is there an increase because people like things that are new? Is there an increase because people are more likely to refer? Is there an increase because the public get wind of it and just come to you anyway? Is there an increase because there seems to be year-on-year increases? And unpicking all of those things is really quite challenging. What we're finding is that we're having to have year-on-year medical staff increases, and that's delivered either by expanding consultant numbers, appointing more ACPs, getting more trainee numbers appears to be difficult now and impossible. So looking at other aspects like physicians associates, and I'd be interested if anyone has experience of physician associates. I think that would be useful for this discussion. But what we're finding, as soon as every year we need to think about a different staffing model, especially a winter staffing model, to work how we get through these bulges. And I'm spending quite a bit of time trying to tell the powers that be, yes, we can go on spending more money on this, but actually looking at just the amount of children presenting would be a good thing to do as well. Our problem in paediatrics is it's very difficult to turn patients away like they can do in adults. And also you're a bundle of risks. So a 7-month-old with a fever probably always needs some form of assessment, but if that 7-month-old is just brought in because that's just increasing the work for the ED without really any net benefit for the family. And I think that's going to be our challenge over the next couple of years. Okay. Chantal, I don't know if did you want to discuss some of your streaming to SDEC from Triage?
Yeah, I'm one of the PemGrid trainees at St Mary's. When I've been here over a year now. When I started, we had this model where the nurses were supposed to be streaming directly to SDEC from Triage, any patients that were felt to be SDEC appropriate. So things like limps, atraumatic limps would be a classic one that was felt to be maybe need a bit more time to be seen, but not acute emergency and unlikely to need admission. That has completely fallen by the wayside as time has gone on, because we don't have enough nurse. RSX is in a separate building, and we don't have the nursing numbers or the trainee numbers to be able to staff that. And it was felt to be unsafe. And that space has ended up being used as a follow-up clinic where the consultants see patients that have been sent home, which some of them probably don't need to be followed up anyway. It's probably just creating more work. I'm sure that it could be made to work in the way that it was planned, but it's how you get the staff to be able to do that.
Brilliant, thanks, Chantal. And what I'm hearing a lot of is there's loads of work as imagined, how we'd like it to do, and work actually is done with the staffing models that we've got. A question on CAMS, patients within this model. So we are really lucky in Leicester. We have something called an all-age mental health team, who are essentially children with kind of the soft to medium mental health concerns can be reviewed by that team. They sometimes wait a long time for it, but we'll have a quick review, and then some CAMS crisis follow-up can be arranged within 7 days. We probably overuse that, to be honest. It's virtually anyone with it kind of mentions depression and they get to see them. But actually that's a great patient experience, much better than it was before, despite some of the long waits. We run into real difficulties with children who have more severe mental health needs or have a social interplay, and we've had recently some extremely long stay patients, 24, 48, 72 hours, because going into the children's hospital doesn't really suit their interests either, and there's nowhere else to go from the ED. But I don't think that is impacted by a single front door model. I think that's just the challenge of mental health at the moment. Helen Stewart was talking about a pathway for tubes and PECs. They go straight to radiology in N hours. Helen, if you could share the protocol for that would be awesome. I'd enjoy looking at that. We've triage, and sharing some of triage criteria. So we have some criteria for being able to send patients to our urgent care system, and I'd be happy to share that with people. What I think one of the national team is interested in doing, though, is what are the criteria that outside the hospital people can use to get patients into an SDEC framework so that they don't need to go through ED. And I think, given with 20 minutes left, I'd be interested in people's thoughts on that, because one of the reasons I personally wanted to have this discussion is a bit of the challenge at the moment between trying to debulk emergency departments, but actually having one point where children could go and be sifted and sorted might actually be is an interesting model in itself. And so one of the things that we from a Leicester point of view, we don't look good for SDEC because all of our children come to the ED and spend a lot of time in the ED, yet we have reduced admission rates. And we're not sure we'd like to go to build another unit where children could go to avoid coming to the ED. I don't know if people have got any thoughts on that or questions. And I've seen people streaming to primary care. Are they happy to share?
Maybe if I want to be a bit cynical about it,
Yep.
the engagement we get from our local GP service, even with the simple idea of making a referral, isn't great. The percentage of children who are just, oh yeah, he doesn't look quite right, you better go up to the emergency department when they see their GP, as well as the 111 situations. I think I love the idea of a framework for same day emergency care, but essentially they're not doing what's a very simple system at the moment. And most of these children are just coming to our emergency department with a letter saying, please see and do the needful, doctor. I think in some ways, I think having a really brilliant framework would be great, but it does actually require people to use it.
Yeah, brilliant. Thanks for that. I mean, that is exactly our experience in Leicester as well. And I'm not glad to hear of your experience as well, but it does make me feel slightly better that it's not just a Leicester phenomenon. And I think there are probably lots of reasons why that occurs. And primary care are, I think, if we're overwhelmed, that they are probably equally overwhelmed, potentially, if not more so. Okay. Yeah, so a question on staffing. Oh, so it's gone to Liz, but it is interesting. There is the conundrum. I know that there are some of the standalone children's hospitals or other hospitals whereby the management unit for the children's ED is the children's hospital. In Leicester, the management unit for the children's ED is the emergency floor or the emergency and specialist unit. And there are pros and cons to both of those approaches, and some of those are historical, and some of those are to do with, I suppose, especially when you have a situation where flow is important. Do you want a system whereby if flow is bad in your department, the people that you're discussing that with are also your direct line managers? And I can see some of the challenges that sets up. Conversely, though, actually, if you have got flow in your department, you've got a business unit that's directly interested in improving that particular flow. So I'd be interested in comments on that or any thoughts on that as well. Right, any other questions? Apologies if people have put their hands up, but I can't see any hands.
Hi, Damien, it's Dave Hanna here again.
Yep, go for it.
I must have one of those invisible hands.
Oh, sorry.
That's it. Just an observation, really. We've in Cardiff, we've long had a single point of entry model on the sort of as a part of a business plan for both the emergency unit and the children's part of the organisation. It's interesting, in the adult world at the moment, there are desperate plans afoot to try and devolve the medical assessments unit part of adult emergency unit to another part of the site, because the adult emergency unit are overwhelmed with a combination of emergency patients and GP referrals, and to see that work underway has made us sort of critically appraise some of the rationale we've always felt was logical behind having a combined sort of single point of entry for children. And it's just interesting to observe the conversations we're having to have with the emergency unit in Cardiff to reassure them that we think it's still a good idea for children to come to the same place in the organisation. It is a very different conversation to the one that our adult colleagues are having, which is trying desperately to offload the GP referrals. It's just an interesting observation. How does the adult world work in Leicester, Damien?
Yeah, with a lot of challenges. I mean, they're even more overwhelmed than we are. There's complete gridlock in the hospital, and there's a huge amount of commissioning discussion about trying to provide other places for patients to be and wait outside the ED. At the same time, because there is no flow, patients are in the ED anyway, and current work is trying to get more medical in-reach to those patients within the ED, and by default, they're almost becoming a single front door model. I think there have even been discussions about, well, should the system just run with that, given that's what's happening? But I agree with you that there does seem to be a bit of divergence here between trying to debulk kind of adult EDs, but potentially provide that single front door for children's.
Yeah. Thanks, Daniel.
I'd miss. Apologies, John. I've just found your hand far away.
Thanks, Damien. Sorry, I'm going to make probably a slightly depressing point, really. But it strikes me that the first of all, the kind of the emphasis on SDEC is slightly misplaced anyway, since, as we all know, almost all of what we do through the ED for kids is SDEC anyway. As you say, like the Shortstay units exist because most patients go home within 24 hours, and actually the vast majority go home straight away. So the point, it just struck me looking at your model of what was supposed to happen, which is patients going to a ward who needed things doing that the ward can't cope with. Well, we're just shuffling pieces around. Like, why aren't the wards being upskilled so they can actually deal with a kid who's on hourly inhalers or whatever? You're virtually having to, it seems like, it was the same when I was a reg with you, and it's the same for us in Birmingham. You've virtually got to cure the patient before you actually allow them to go to a ward. And actually those things are what matter. I think, this kind of, let's have same day pathways for kids with, to pick an example of someone said earlier on, like limp. Well, if there's enough flow through our department, we can deal with a limp patient in less than 15 minutes. They don't really need to have their own separate unit. We just need enough flow so that someone sees them at the right time. But actually, as much as I think the primary care streaming is a big help, because that does, for want of a better expression, it does pull off a lot of kind of low acuity stuff, and it just reduces noise for us in the evening. I would say, if you can send 25 patients elsewhere, it's just 25 less patients to worry about because you're dealing with the high acuity ones. But actually, the problems everyone's coming up with, staffing, some places more than others, it will be simple physical geography of enough spaces. And yeah, as Lorna's just put on the thing, it's deck chairs on the Titanic. We're just finding ways to shuffle pieces around to convince ourselves that something is being done better than it was being done before, when in practice, it's the flow that's the issue. And the ward, that must be incredibly frustrating that it wasn't allowed, but equally it's frustrating it was even suggested that you need to have a holding bay for wards because you're sending patients to wards and the wards aren't capable of actually looking after them. It sort of needs buy-in from everyone, really, doesn't it?
Yeah, thanks, John. I mean, I'm interested in your comments on getting to the wards, and I think it'd be useful if people could kind of share if that's what it feels locally as well. I was of the opinion that might be a local phenomenon, but it's interesting that you've experienced the same in Birmingham. And you're right. One of the things that you could maybe SDEC is creaming off the easiest well patients to stop them bulking up the ED. But will that process actually mean that patient spends a bit longer, and it's much better for the quick wins to be dealt with ED? So there's some really interesting points there. Okay, I saw Javid just had his hands up, but that's gone down again. Bob Basu.
Hi, Damien. Yeah, it's just an experience really here at Bradford. So I think one of the problems that we have here with the nursing, so there seems to be a rule for the wards upstairs where they have to have a 5-to-1 ratio, so 1 nurse to 5 patients. But in the ED, we can have 2 nurses and have 60 kids running around. And that's where we get the gridlock. So we can't send kids up because it overloads their ratio, and we then have to look at sending kids elsewhere. I don't know if anyone else has the experience on this, but I think one of the things that would be helpful if that ratio could be increased, and that would improve flow in our department. I know that's something that we talk about quite a lot. I don't know if anyone else has any sort of experience on that.
Thanks, Bob. I think that's probably a shared experience, and this distribution of risk is a common challenge, and sadly, I think quite a source of a lot of tension between emergency departments and wards about who's carrying how much risk. Yeah, it'd be good to see people's comments on that. Probably I'm keen to close at 5. Claire Miller, you've put an interesting comment about same week emergency care pathway. I don't know if you've got a microphone, but you just wanted to describe that.
Yeah, so we've done something slightly different at Barnet. So what we've done is we have our PAU got closed in COVID, so we've lost that, and we also don't have an observations bay. So we either have the ward or ED. Everything that comes in acutely will come in via ED, but a lot of it doesn't actually need to stay in ED, but then can have immediate things done in the following day. So like appendicitis that can go home and come back the next day for an ultrasound, or a limping child that doesn't need to be there but can come back in 3 days if it persists. So we've done a face-to-face and a virtual option for basically offloading the back of ED. So everyone comes in through the same door, but if they don't need to be in ED at that point, but they need something happening within the next couple of days, up to 7 days after their discharge, rather than either representing to ED or taking up a valuable space on the ward, we've instead developed this same week emergency care service so that those people can have a direct access to a separate outpatient area where they can come up for 3 hours to have whatever it is that they're needed. And by doing that, we've now managed to avoid over 1,500 admissions in a period of a year. And that's reduced because we've got such a reduced bed base, that has been a different kind of model that we've gone for.
Was that difficult to implement? I can see it be quite challenging to work out who, because you need to spend not long with the patient, make a really early decision. Actually, you can go now and I'll sort you out in a couple of days.
Yeah, so that's basically the thing. So the idea is that they have to, it's involving having senior decision-making people present in order to say, well, actually, this is an emergency. You don't need this now. Go away and come back at this time. And we're now considering how far down we can go with that in terms of expanding things on the phone before they even get here, to allow more direct access to GPs to those sorts of appointments that don't actually physically need to be on the same day. Could that be something where we now expand that to? But the safety check at the moment is that they all come through the PEDS service. And they all have that face-to-face within, or virtually within 7 days. So you've got another option.
Yeah, thanks, Claire. Do you include headache in that?
Yeah, so anything without red flags. So you would argue that a lot of that would actually not need to be coming back acutely. So you could ask your acute questions, and then you're then saying, well, actually, is there anything that, like, if that child needs an MRI within a week and needs to be seen face to face with results, and that would be ideal for it. Yes. Okay, thanks for that. Okay, that's a interesting approach. Okay, I don't. John, is that a legacy hand or?
Oh yeah, sorry, I'll take it down.
Okay, nice, cool. Okay, brilliant. Thanks all. As with many of these things, and I remember doing a similar COVID one probably about 18 months ago, where I don't think there's actually any direct solutions offered. But I hope that some of the shared ideas have been useful. This has been recorded, and I will share the chat so people can potentially share with colleagues. I do think in the chat there have been a few people where people have got maybe some SOPs or some ways of doing things that might be useful for the wider community. And what I can do is, if you can send those to me, I can use the Eventbrite to send them out to the wider community, and or converse with Jane, and we'll get that sent out via APEM. I think that there is probably a lot more to come on this. And it may well be that we have another group discussion at some point closer to the beginning of winter. If there are things that we've not picked up that people wanted to answer, please do send them to me, and maybe I can kind of stick that out via the group. And Jane apologizes, she's on a computer, but she can't talk. She was going to talk a bit on behalf of APEM and Southampton. I do hope those of you who are coming to the RCPCH conference in Liverpool, our first face-to-face get-together in a long while, I look forward to seeing you there. But otherwise, I will call things to a close. Really, thank you so much for attending. We had about 105 people at one point. So this is clearly an important hot topic. Keep well and keep safe. I'll speak to you soon.
Thanks, Damien.